anything when you think about you're making someone go to the restroom because they have constipation, you actually hydrating and making sure that you hydrate is a big deal, right? So like any of these things, especially if we overshoot and we overcorrect, we are worried about our patient remaining hydrated, okay? So that is your big thing when you're having them take these medications, and then letting them know that that bowel movement is their stopping point of them taking these, okay? Like they're not going to continue to take them. This is like an as-needed type of thing. If you're looking at like cancer, or if you're looking at like your patients who are like opioid-induced type constipations, those medications we put them on for longer periods of time, okay? But for the most part, these are like your acute type situations where you're trying to help those patients in that situation. Again, when you're talking about like a fleet or a suppository, just make sure that they're not impacted and that that medication can actually penetrate, because they're inserting it in the rectum, and so if it can't get past the stool to get further up into the bowel tract to like actually work, the med isn't going to do much, okay? They're just going to keep straining and keep trying to go to the bathroom, and then it becomes a bigger problem. Okay. Inflammatory bowel disease is a little bit different. This is where we were, right? So this is a little bit different than when we're talking about our IBS patients, okay? So there's something that is going on, whether it's colitis or Crohn's, where they have this disease that is caused by abnormal, like an autoimmune response, essentially, okay? And so they're starting to attack the GI tract, and these patients are on medications for a long period of time. Our medications are managing their symptoms. There is not cures that we have for these conditions. So we are essentially just managing our patient. Here are all of our different medications that we have available for us to treat. Some of these you will see again next semester when we talk about things like rheumatoid arthritis. You'll see these used. So any type of like autoimmune disease, sometimes you'll see some of these medications used. So we're going to go through and highlight some of these more important ones that you're going to see. More like your amino salicylates, these are ones that you're going to likely prescribe, or you will see a patient on these medications, and you just need to make sure that you're aware of what they're using them for. And then sometimes you'll have to give those steroids, especially if somebody has like a flare in one of these diseases, to kind of help calm down the inflammation that they are going to experience. Yes.
You know how like the last block, whenever we saw metro, Tylenol typically also work? Is that the case in this situation?
What do you mean, like, what do you mean?
So, in every instance I can think of, we could use metronidazole, you could also use metronidazole.
So, in this situation, when we're looking at it, the only reason why we have this here is because of us talking about, like, different types of infections or bacteria that could be infecting the GI tract. So, don't associate it that way. Just specifically looking at these two antibiotics, your Cipro and your metronidazole, when we're talking about like these IBDs. Okay, so just look at these two. A little bit different because we're treating different bugs. So this one just focus on these that we have here that we'll talk about. And then also, you're going to see lots of names on this side. This is just letting you know like where they're falling. If you don't see a single, like if it's not on here, then there's nothing else that I need you to know about it except for the drug class, right? So I could be like, oh, what's a TNF alpha? And I could tell you like, oh, a patient has IBD. I could say it's Crohn's or colitis, whatever. I could say your patient has IBD. What's a TNF alpha that you could choose to prescribe to that patient, right? And then you're like, oh, my TNF alphas, these biologics in with MAB, and these are the ones that I have. I haven't written yet, so I don't know what this will look like. Whenever I post some questions for you guys for a review, I'll tell you like and kind of direct this a little bit more. Okay, but just be familiar with the classes because you're going to have to also learn it anyway next semester. So just take a look at it. So these are our different treatment options that we have available, right? And this is giving you the main adverse effects that your patient could potentially have. So when you're looking at this, again, am I telling you to remember about a headache and some nausea? Probably not. When you're seeing the things that are a little bit odd, joint pain, right? So when we're looking at our sulfasalazine, oh, I have something where this is causing joint pain. That's an abnormal adverse effect. Look at the things that stand out for someone and not necessarily saying like, oh, they have a headache, because I can tell you that with any medication, right? I can tell you GI with almost any medication. Unless you see like that parentheses around it where I'm giving you like, oh, it's 30% of your patients, oh, it's 80% of your patients that's gonna complain about this, then that's when you're really worried about those. Looking at your mesalamine, lesser extent when we're talking about the pains, more patient-friendly than our sulfasalazine. Looking at our glucocorticoids, we'll learn about these next semester also, but making sure that you understand whenever you have somebody on a steroid, we don't want to leave them on a steroid for a very long time. Steroids are great drugs, but they have nasty side effects the longer that you use them, okay? Azathioprine, again, big things here. All of these are very important things, right? Because they can affect several things. So bone marrow suppression, when you're talking about pancreatitis, like these are big things that can affect our patients. And then this TPMT activity, that's just making sure that you're seeing like, hey, is this going to be working? Is their enzyme working for them to break down that medication? Your methotrexate, again, drugs that we're going to talk about in more detail next semester. So that's why here it's just giving you like just a snippet of the side effects that you can see, and then looking at the treatment options that we have, okay? Cyclosporin and tacrolimus, you'll see these used for several different indications. Good medications, again, nasty side effects, so you see all the toxicities that you can have, those electrolyte imbalances. Your anti-TNF alpha, these are going to be medications that your patients are going to come in most of the time to get infused. We do have some that are sub-Q injections for them, so that's why you see those infusion-related reactions. We have had some pulled off of the market because of the heart failure that occurs. You'll also see sometimes TB and hepatitis reactivation in these patients, so we test for that prior to putting them on these medications. Their cancer risk can increase, so it's good for managing, the condition. So that's why we're kind of, when you think about this, you kind of are trying to see how severe a person is and reserve some of these things as we get towards the bottom. Like this is a progression of their disease. So starting from the top of like, oh, they're not too bad, they're mild, because remember, this isn't going away, we're not curing it. And then as their disease progresses, we start to progress with what we're putting on board. Because as you see, these side effects get a little bit more serious, cancers, things like that, okay? When you're looking at your JAK or your Janus kinase inhibitors, your JAK inhibitors, these are like your very last line, more expensive meds that you're going to use. And they have a black box warning that's attached to them for thrombosis. So if you have a patient who has that underlying disease state already, where they're clotting a lot, this can be very detrimental and fatal to those patients. All right, IBS again. So there's two different ways that your patient can present with IBS. You have constipation and you have diarrhea. You have some people who have a mix. Some people will just say that they're only aggravated whenever they're trying to use the restroom. Some people will say that they have pain that is occurring to them all the time. And then some people, they're just consistently bloated because they have IBS. So just understanding that these are some of the same medications that you saw previously when we were looking at our constipation. And then you see the diarrhea. We talked about some of that loperamide. You have your antispasmodics that we'll look at, rifaximin, antidepressants, several different meds that we'll talk about. So again, just know that you have several options. Some of these we're going to go into more detail about. So your lubiprostone and your linaclotide, these are the same exact slides that we saw when we were in that constipation section. So you can look at it here or you can look at it there. Just remember that your indication was for IBS, okay? So again, I'm trying to increase motility. They have constipation. I'm trying to help them. So understand which ones are for constipation, which one you're using to help your which one is for constipation and which one is for diarrhea, okay? Because your constipation, you're trying to increase motility, and with your diarrhea, you're trying to help them stop. They have too much motility, okay? So same drugs that you've already seen. This one, your tegaserod or your Zelnorm and your tenapanor or your Ibsrela. These are, again, two oral medications that we have for our constipation. Looking at your mechanism of your Zelnorm, you see that this is hitting that serotonin. So remember, anytime you see 5-HT, that's talking about your serotonin. So it's an agonist, and it's trying to help them get things moving, right? Because they are constipated. So enhancing the vasomotor activity, helping with that sensitivity and just overall gut motility, right? Getting things moving. Very normal adverse effects, nothing that we're really worried about. And if we give them too much, of course, we're going to see that diarrhea happening. Contraindication. So these contraindications are important with any of our meds that we're trying to use that are going to increase motility. If there is an obstruction, it doesn't matter how much you try to move things. If there's something that is blocking it, now you could just be causing that patient more harm, okay? So you're always gonna say like, cool, if this medication isn't working and my patient hasn't started going to the bathroom within that 24 hours, I should be looking and being like, okay, is there something else that I'm missing? What other workup do I need to do? So that's why you ruling out an obstruction is very, very important. You see MI, gallbladder disease, if somebody's had a history of strokes or repeated strokes, like just make sure that you're watching out for that. Our Ibsrela, again, mechanism of action, this is a different one that we haven't seen, so inhibiting that sodium hydrogen exchange, make sure that you're looking at that and paying attention to the fact that we're, again, trying to improve. Yes.
All right, let's stop for a second. You guys are tracking that the government shut down last night, right? Okay. If you're not, then you need to start looking at the news a little more. Okay, so what does that mean for us, right? All of our civilian staff, right, have been furloughed, which means that they get to go home without pay. If they're essential personnel, then they get to stay and work without pay, right, until things kick back up. If you're in the Coast Guard, I don't see any coasties in here. Then they fall in the same category as the civilian personnel, which means that they don't get paid until the government has money to pay them. Okay? For us, unlike the last government shutdown, there was a resolution to continue paying applicants, right? They did not do that this time, which means that your current paycheck should have been paid on the 30th or yesterday. But if it continues beyond the next pay period, then it may affect all paychecks. Okay? If I hear differently, then I will certainly let you know. You may see some changes in some of our faculty. We did an exception to policy for the civilian staff, so that they will be retained as essential personnel. But that still needs to be approved by our high headquarters. So we try to minimize the impact to you guys. So all the swelling and the churn is happening above your level and certainly above at my level and above. Any changes to that will be good. IPAP is doing well in the sense that we have not had to shut down our doors, unlike some of the other programs in medical. Right? So you may see less people in the building. That's because some of the other programs shut down. Right? No, that's not a good thing because then you still have to make up free work. So don't wish that you were on these guys. Okay? Main thing is that just continue to do what you're doing. If you hear anything different, come find one of us on the faculty and we'll try to dispel any rumors, okay? But for right now, you continue to come to class just like you normally would on any given day, right? And study. No, it will not affect your exam. You still got to take your exams on Monday and Friday. Sorry. Okay. Now, if you guys have any questions about it, any guard and reserve in here? Okay. I checked with the liaisons and especially for the guard, it's not affecting you, so you guys continue to drop on just like you do in that level. Okay? Reserves, still waiting to hear back, but I don't think it's going to affect you because you kind of fall in the same category as we do. Okay? Come see me if you have any questions. I'll be happy to answer what I can.
All right. Come on. Okay. So back to our patients who have constipation, right? So yes, did you have a question? No, did you have a question? You're like, yeah, let's get back to constipation. If we don't get paid, I might be constipated. My money. So if y'all do need anything or stuff starts to, if it gets prolonged, like you said, just come and find one of us and we'll try to help direct you. So looking again at your mechanism. Now, whenever I told you guys before, right, if I'm talking to you about an adverse effect, and you see a percentage in it, then that means that it's significant for that drug, right? So again, with this is saying with your Isbrella that I can be at a normal dose, and even with that normal dose, I could potentially see a lot of my patients experiencing diarrhea. Like, it's very effective. With that being said, make sure that anyone that you're using this medication in is over the age of 12, okay? It needs to be over the age of 12, so avoiding your patients who are under 12. Your allocentric, big thing with this, again, acting on that serotonin receptor, so antagonizing it. When you're looking at this, big thing here, again, I'm going to help my patients who have diarrhea. So pay attention to the top, because every time that this changes for those drugs on that slide, I made sure that I labeled it IBS with constipation or IBS with diarrhea, so that you know which one, because they're for two separate reasons, right? Don't mix these up, because you can make that other person's condition worse. Then looking at your black box warning. So when we see a black box warning, remember, again, very important. So when we're talking about the ischemia colitis or the extreme constipation that they can see, when we're looking at colitis, just think about this as they're having decreased blood flow to their bowels, and essentially what happened was this was so bad, they pulled it off the market, and then they put it back on the market, but now you have to do this Prometheus prescribing program. So it's kind of how we were talking about before, where like the pharmacist, the patient, and the prescriber are going to all have to subscribe to that program, and we all have to say, yes, my patient is aware that they can potentially have this ischemic colitis occur to them, and they also are aware that the constipation that can occur is so extreme that it may end up in them getting surgeries, which could lead to a blood transfusion, which could lead to death, all of the things. So just make sure that you're understanding that this one is, again, something that's coming with one of those additional programs because of the black box warning, okay? So not a drug that I'm like is going to be the first thing that I reach for if I am trying to help my person who has diarrhea, my IBS diarrhea, okay? TCAs, SSRIs, we're going to talk about these a little bit more in the next block, but understanding that these are drugs that we typically will see used in our patients who have depression, but we can also use these in our patients who have IBS. So you have your amitriptyline, nortriptyline, and your imipramine, which are all TCAs, and we're trying to essentially help with some of the pain, and we talk about these again in pain, because sometimes when patients have pain, we can also use some of these TCAs to help with that as well. Looking at your IBS with diarrhea, it's typically where you see us use them. You can use it in your IBS with constipation, bless you. But because of the anticholinergic effects, you can see where sometimes your patients will have worsened constipation. So largely we use these for our IBS-D. And then looking at your these doses. So a lot of people always ask this when we have a drug that can deal with two different disease states. So when you're saying this, what this is saying is that for you to effectively, like if you were just trying to treat IBS-D or IBS-C, those doses are very low to where if you did have a person who had depression and you were wanting to use a TCA for an antidepressant, the dose would have to be a lot higher. So don't think like, oh, they're on this low dose for IBS, and so therefore it's treating their depression. No, they would have to be on a greater dose for that depression, and then we would try to see if we were going to get a benefit for our IBS-D or C in that patient, okay? Looking at your SSRIs or your selective serotonin reuptake inhibitors, these you have fluoxetine, sertraline, citalopram, paroxetine. Just remember the names in this manner for now. When we talk about our antidepressants, you're going to learn about their mechanisms and all of that good stuff. But just understanding, again, it's helping with the pain, and they're pretty good in IBS-C or D. So our quick check on learning, which of the following is not a limiting factor for selecting a biologic agent? So I told you that you're going to have to screen for any like other hepatitis, TB, because the biologics will reactivate. So anytime you see biologic, think of the ending that says MAB, okay? Monoclonal antibody, those are biologics. So that is something that can happen. Affordable cost. So these are very expensive things, which is why I told you like they're going down, right? So they're like towards our last line agents that we would use. So when you see this affordable cost, that's That's your correct answer. It is not a limiting factor. This is not a limiting factor. Hold on. Increased risk of cancer, infusion reactions. Yes, this is written horribly. Okay, that I wouldn't do it that way. Don't be on. Don't do that. Okay, I update slides often. Okay, and if you hard again, then maybe I will try to go back to testing committee. I'm trying to go back to testing committee, by the way, so that I looked at a couple more and I read them and talked to them. I talked to the question didn't talk back right to me, so we're going to talk about it in testing committee again and see if we can get some more points. So I'm working on that. Okay.
Get us in trouble.
Increased risk of cancer. Remember, I told y'all that we were worried about increased risk of cancer and those infusion-related reactions that we can have because some of our mAbs are sub-Q, but some of them are also going to be infused, and your patient has to come into the clinic for them. Okay. So just know they're very expensive. This is an issue that we would have. This is a limiting factor for us. That's a weird way to say that. Okay. So make sure that if you have any questions, that you let me know. I will, for this section for a review, I may put up like some questions for you to have. I don't know if we will do one in person. Y'all do have, we'll be done teaching probably tomorrow. So I will be around, just not, I won't be around on Friday, but every day after that, I will be here for any questions that y'all have. Just contact me like you normally do. Okay, let's look at our anticonvulsant lecture since it's the longest one. Parkinson's is 33, isn't it?
Yes.
Don't be confusing me, okay? I'm having a tough day. You making me more confused today. I'm Confucius, okay? Let's look at I'm Confucius. Let's look at our anticonvulsants. So when we talk about anticonvulsants, you have some people who have diseases that are going to cause them, yes. The one, there's like the slide with all of those drugs, and then, I closed it. Hold on. Go towards the end when we were talking about IBD, and then it had like drugs on the left side and the right side. They were on the right side, and then there's a table that starts with sulfasalazine, and then down at the very, very bottom, it has some of the biologics listed there too.
It says all biologics screen for TB.
Yeah.
Nothing tells me which ones are biologics.
Go to the slide before that one.
Okay.
Do you see the let me open it so I can tell everybody so that you can see it. Where's that lecture? They're towards the end on like the right hand side. So when you hit like these, all of these down here, those are all the biologic ones that are telling you about cancer, but I thought it had it over here. So any of these that are on this side, these are all biologics. And I will go back. I wonder if I lost that when I reformatted it. I'll go back and I'll label that again. But all of these that are on the right-hand side are your biologics that you have. Most of them will end in MAB, except for your JAK. So these are your biologics. Everybody got that? Okay. The biologics, and then the things that are on this slide where it was telling you some of the stuff about them, TB reactivation, hepatitis, because we're going to go into this next semester in like great detail. So you using them for IBD is like that's not how we use them more often for what we're going to talk about next semester. So this is just like a little byproduct of what we're gonna talk about. So our anticonvulsants, when we're looking at these, there are several different disorders and disease states that patients can have that could cause them to convulse, right? And so with our medications, what we're trying to do is terminate whatever that seizure is that they're having at that time. Sometimes when you have patients who have TBIs, for several years after they have that TBI, they're at an increased risk of developing and having seizures that start to occur. And so sometimes we'll put them on these medications. So we do see a lot of the time in the ICU where we will start our patients on some of these anticonvulsants. So great medications, very important medications for us to touch on. Bless you. Looking at our ELOs, same things that we always talk about. So whenever you're studying at this, look at your mechanisms, look at the drug class, look at those adverse effects, especially the weird ones. Looking at, I don't think I make you remember any doses in this, your contraindications, what you're using them for. You're going to learn that there are several different types of seizures that somebody could have. When we go through this, I am not talking to you about all of the different types of seizures because you're going to learn that. I am going to tell you what they have, right? So when you're seeing, oh, I can use this one for this type of seizure, just understand right now that it's just for that type of seizure. When you get to your ologies, they're going to teach you like, hey, this is what this type of seizure is, and then y'all will go over the medications again, and then it was cemented further, okay? So, like I was telling you, when we have our medications, what we're trying to do is say, hey, I want to control this. I want to stop this patient from seizing. I want to help them have a good quality of life and make sure that they're not seizing often. Depending on what type of seizure someone has, some of these are they're very dangerous. Some of them hurt a lot, like hurt your patient. After they're done having the seizure, you can have sometimes where people like have a head injury, depending on what they were doing whenever their seizure started. They could have fell, hit their head while they were convulsing. They were hitting their head on the ground, and no one was there to kind of help them, like roll them over, brace them a little bit. So there's several different things that we're worried about when we're looking at our patients. Making sure that you understand that the type of seizure is going to dictate what type of medication you're going to use for your patient. Making sure that you are also starting with a dose that we try to start with a medium to low dose, right? And then you start to escalate those doses if you see that your patient is still having seizures, or if you see that you can't terminate a seizure that patient is having. So when you see like, oh, it's rare to administer standard doses, this is just telling you that it's patient specific. Everyone may be different, okay? So you can't be like, oh, you're a patient with a seizure. Like, this is the dose that I'm typically giving. You're doing it based off of how many seizures they're having, how often are they still continuing to have those seizures once you put them on medication. Because if I have you on an anticonvulsant and you're still convulsing, that means that I'm not too anti, right? So my dose may be incorrect. I may need to change it to a different drug class if it's not working. So just looking at this, making sure that you also understand there's a lot of monitoring that goes with these medications because they have narrow therapeutic indexes. So remember when we had our narrow therapeutic index, anything that knocked me outside of that therapeutic window, I was extremely worried, especially if I went above it, right? Because now I have those toxicities. If I was below it, then that means that my med wasn't working, which means my patient is likely convulsing, okay? So, or convulsing more than I would like them to. So just make sure that you're understanding that you are trying to, again, make this patient's quality of life as good as you can with our medications. The least medications, of course, the better. There are some situations where we will have our patients on multiple anticonvulsants to try to make sure that they are not seizing, okay? We used to put people on these meds and be like, you are on them forever. Now what we're trying to do is we're trying to say, all right, I'm going to put my patient on a medication, and if they haven't had a seizure in 2 to 5 years, most people are more safe than sorry, again, depending on what type of seizure that person has, depending on your patient and if they have been compliant or not. But 2 to 5 years, then I will say, okay, I'm going to try to withdraw my anticonvulsant, right, because these have side effects. So I'm going to try, and they have monitoring. They make us do more work. So we don't want to leave them on them anymore for forever, right? So we're trying to withdraw them. 2 to 5 years, no seizure, then you're trying to take them off. You're making sure that you're going to do all these exams, you're going to do EEGs, make sure that everything is fine. And then if they have another seizure, then you would, of course, put them back on their medication. So because their body has gotten used to them taking this anticonvulsant, when you do take them off of this medication that they've been on for a very long time, you're going to taper them off. So when it says withdraw medication slowly and one at a time, I am going to taper off a dose. So if I was on one medication, then that's easier for you to get me off, right? Because now I'm just going to taper that dose down before I pull them off of it. And then you can look up the tapers. I don't expect for you guys to remember tapers. Y'all can look them up. And then depending on what facility you're at, they may have a protocol for how they want you to taper. So some people, what I mean by a taper is you may have me on 100 milligrams, and then we would say, okay, every 2 to 3 weeks, I'm gonna taper her off by 25% of whatever her dose is, right? So every 2 to 3 weeks, we would drop my dose down and continue to drop my dose down until I'm off of the medication. So that is a taper. We do that with several different medications. So anytime you hear taper, we're just stepping them off of their medication. And then if I'm on several medications, don't just yank everything at once, because my body is gonna be like, what the heck? What are you expecting for me to do now? I'm likely to have them have a reoccurrence. So I'm going to, again, start tapering one medication, get them off of that medication, then start tapering them off of the other medications that they're on. So one at a time, okay? And slowly. Yes?
If it does go on for 2 to 5 years, would you try to keep it off after 2 to 5 years? Or?
Like if they have another one, yes, we're always trying to get them off. So depending on where you pick, like if you picked that 5 years and they were seizure-free for 5 years, right? They were stable on their meds, and then you pulled them off, I would probably leave them on the next time. Granted, it's out of this window, but I would use my clinical judgment, which y'all will start doing. I'd be like, okay, well, the 5 years didn't work last time. Maybe I'll go and see, like, you need to be seizure-free for 6 years, and then maybe we can try to start tapering you off. And I would just kind of play around with it. It's not going to be this clean. Trying to get people off of these meds it's very hard. And some of them will become very afraid depending on how their seizure was. They may be like, no, like this is my safety blanket. Like I haven't experienced a seizure and I don't want to. So when you try to tell them like, oh, we're going to taper you off, they might be like, what? So just make sure that you have their buy-in and that you have a plan for if they do seize again, like what that looks like for them, what they should be doing, and how, what is their safety plan, essentially, is kind of what it is. So that, to answer that question, because it's a wide range, if you pull them off and you said, oh, you were seizure-free for 2 years, and I started to seize again, then you'd be like, oh, maybe I didn't leave them on it long enough. I'll extend that and go to 3 to 4 to 5 years. And then I'd be like, okay, let me try again. So we always will try to withdraw. Not saying that this will always be successful, because some people, we can't take them off, and they're on them for a very long time or for forever, lifelong. Okay, these mechanisms. So, how we had our antibiotics, right? And you can remember, oh, cell wall inhibition is like the mechanism. Cell membrane inhibition is the mechanism. These are different for almost every single one of these. So looking at your mechanisms, this is what makes this more difficult. This is why I broke up this block with the next block, because when we talk about antidepressants, it's the same thing. They may have a group, right, anticonvulsants or antidepressants, and we'll say like, oh, it's an SNRI, but all of the SNRIs may have a different mechanism, okay? So this is, when you're studying this, look at this completely different than how you were looking at grouping your antibiotics. This is going to be more difficult for you to group because mechanisms will vary depending on the drug that we're looking at, okay? So we're gonna look at these and kind of talk about them. So when we're looking at our anticonvulsants, just think of the fact that like there's some type of electrical discharge that is happening, which is making this person have the seizure, okay? So when we have an anticonvulsant, we're trying to stop that transmission of that electrical discharge. When we talk about enhancement of GABAergic transmission, is our GABA inhibitory or excitatory? What do we say? Inhibitory. So I want to enhance the inhibitory actions so that I can stop the firing. I can stop the convulsing. So I want my GABA to inhibit more, right? I want my GABA to stop the transmission that my patient is experiencing, okay? I don't even like this word. Diminution, okay, or decreasing the excitatory excitatory transmission that that patient is experiencing, right? I am convulsing. There's shots being fired. I want to decrease that. I want to stop that, okay? So when you're looking at these two things, those are the big two things that I want you to remember, is that I'm enhancing my GABA, which is inhibiting, and I'm trying to stop that excitatory signal that is being sent that's making me convulse, okay? I want to stop those. Stop the excitatory, enhance my GABA, which is inhibiting for you too, okay? These are several different medications that we have. When you're looking at the ones that have a star next to them, ironic, like when we talk about some of our medications, these can now increase the risk of somebody having a seizure, but we do use them, and they're common ones that we do, so we just monitor. Because remember, those therapeutic windows, the narrow therapeutic windows. We'll talk about like antiarrhythmics next semester. When you talk about an antiarrhythmic, the side effect of some of them is that they are proarrhythmic, and you're like, but that's what I'm using the drug for. Same thing when we're talking about these anticonvulsants, right? I'm trying to stop a seizure, but I could potentially aggravate or make it worse whenever I'm using some of these meds. So what I want you to focus on are the drugs that are in the bold when you're looking at this, because there is just a lot of them. You're also going to see a lot of them listed here, but then I'm not going to talk about them throughout the slide. So if I don't talk about them throughout the slide, don't worry about it on here, okay? The ones that I'm going into detail on the slides are the ones that I want you to worry about, okay? So again, our bold are the ones that we're typically using the most, so that's why you see those. So that's your main focus. That's what I want you to look at a lot more, okay? Again, you'll learn more about the different types of seizures. We're not going to go into it. Just know, like, hey, I'm using this drug for this type of seizure, okay? So focal, generalized, and then your absence seizure. So when we're looking at this, you have phenytoin, which is your PHT, carbamazepine, and your oxcarbazepine. So when we do each of these, you're going to see the box around the drugs that we're talking about, okay? So this is letting you know these are the drugs that we're talking about for every single one of these as we continue to move through, okay? So all of these drugs will then share that same mechanism. But I want you to focus on the drugs that I have highlighted here. Oh, because I zoomed in my laser. The drugs that I've highlighted here. So that's how we're going to do our flow of this, right? Red box is telling us, hey, this is where these drugs work. These are the big drugs that I'm focused on, that I'm going to use more in practice. So what these are doing is they're blocking this sodium channel right here. So phenytoin, carbamazepine, oxcarbazepine are blocking your sodium channel. That is your mechanism of action, okay? All right, phenytoin, very popular drug, several different formulations. We use this in an inpatient setting. We also can have our patients managed on this because it has an oral formulation that's available as well. You see that we have several different seizures that we can use it for. So our focal, generalized, status epilepticus is a very serious seizure that sometimes is kind of like can become refractory. And then you're off-label for several other different types of seizures. So again, so many seizures. Your big thing that you're looking at is like, okay, which ones are used for which ones? So which type of seizure? So looking at that first chart is kind of like your summary chart to say, okay, where does this one work? Looking at your PK parameters, understand that because I do have a good good bioavailability, that is why I have my oral formulation that's going to be available. And then your zero order kinetics, all the things that y'all have heard us talk about before, highly plasma protein bound. So when we talked about our protein binding, you'll see that sometimes we have different variability in how a patient will respond to phenytoin. What that means is I may have more protein that does binding in my body than the next person. So that's why when we talk about like individual dosing, your dosing is individualized based off of that patient, right? Because we have several different makeups, genetic makeups, and then these things will affect our PK parameters, okay? So highly protein bound, so if you have another drug that is highly protein bound, now you have them competing for these proteins to bind, right? So now what that can do is increase the effects of one of these medications. So if I'm bound, do I have action or no action? No action. I'm in a relationship, I'm getting no action, right? We are bound, okay? What happens to some people in a relationship? No other action, okay? No outside action. That's what should happen when you're in a relationship. So bound, I am just stuck right to that thing. Now, if I have somebody else trying to compete, I might get kicked out of my spot. I'm going, no. So when you have that, now the effects are going to be all off, right? So just remember, if I am bound, I'm not acting. If I am free, if I am displaced, now I have less protein binding, which means my drug now can act more, right? Because it's free. Looking at our administration that you have your IV, you have your PO, we have the tablets. For our kids, which is very important, we also have solutions available, or for people who can't swallow tablets, so this is a good option for us to have. Looking at your IV formulation, just make sure that you're looking at the risk. I don't care if you know if it's basic and all that stuff. I want you to look at that extravasation and the hypotension that can happen. So when you talk about extravasation, again, that is if I had my line, right? I ran my line and I have my bag hanging, and I'm infusing my medication. If I infuse this medication too quickly, I can have to where it extravasates or it leaks outside of that vein and can lead to several issues. So when you are running any type of medication, I always tell y'all to like go back and check in a couple of minutes to see how your patient is feeling. See if they're turning red by that, by where you have your line going in at. Because if they are, it could be that that medication or your patient moves around and does crazy things, and the needle slipped out, right, of where it's supposed to be. It's happened to my daughter before with her meds, because she's a kid, and she's in there, and she's like, oh, and doing this, and can you turn the TV, right, and doing all the things. And one time we looked at her, and she was like, oh, it's hurting, and I was like, it's just your medicine, it's fine. And I'm telling y'all this because I do stuff like this. And I was like, you know what, I need to listen to her. So I go over there and I look, and her arm was starting to turn red and kind of swelling up, and the medication wasn't going where it was supposed to, right? So we stopped the line, fixed it, and it was fine. It didn't make her tissue die, because some of our meds will cause the tissue necrosis because of our extravasation. But that wasn't the case because the med was fine. Yes?
This will go on a pump, right, not gravity?
Say it again?
Will this go on a pump, not gravity?
Yeah, this will be on the pump. Most of our stuff that we talk about, most of them are on a pump. Like you're doing it in an inpatient, kind of clean setting, not necessarily just gravity. Yes?
Yes, ma'am. Is it primarily used more for focal or generalized seizures? I was just looking on the clinical use. It has both, but on the chart it's only under.
So when you look at this, I'm going to also look at how I'm going to write this exam to see how I'm going to focus this, because this is a lot to remember. And I don't know why I keep sympathizing with the a lot to remember part. But I also am trying to be rational in what you can, like, some of it you want to know off the top of your head, right? But some of this is like, okay, you would look it up, realistically speaking. So I'm going to look and see how I want you to remember this. If you're looking at this, remember what is on the big summary chart, because I like summary charts, so I will go off of that if I do make you remember it. And I will tell you guys by tomorrow if I'm expecting for you to remember every one that's listed on here, or just the summary slide, and I will tell you if I'm even going to ask you a question that way to know the clinical use, because I don't know if I want to. I'll see. And if I do it, I might direct you even more to tell you, I want you to know the uses for this particular drug, and maybe not all of them. So I'll look at it and see. Whenever I write. Your PO, make sure that you're understanding that you have a lot of adherence to your tubes that could occur when you give this medication. So if somebody had like an NG tube or something like that you're having to give this through. Because when you think about seizures and people who need these medications, sometimes there are several different comorbidities that are happening. Some of them are immobile, some of them may have other things going on. So just understand that this can also be bound to those feeding tubes and to some of the nutritional products that we can give our patients if we were also feeding them through a tube. Okay, so when we think about the ICU, this comes into play with the solution. So most of the time we'll run the line instead. Looking at our adverse effects, this is a drug that they love to test us on. Pharmacists, doctors, PAs, everybody. I don't know why they love to test on this drug, but I put this lady so that you can remember all of the different side effects that someone could have. So, you have dose-related and non-dose-related adverse effects. When you're looking at your non-dose-related, that means it doesn't matter what dose you have me on, I can experience this side effect. Whereas when you look at your dose-related, the higher the dose of the medication that you're giving the patient, the more likely they are to experience these side effects. Okay, so that's the difference between those two categories. When you're looking at your non-dose-related, think about the fact that you can have sexual dysfunction. So again, I have that up there because that is very important for your patient to know, right? When stuff isn't working that they use, they're worried about it. And that medication is going to be the first thing to go if they don't know why it's happening. So you need to tell them, hey, if this is happening, if you experience this side effect, come back to me. We can look at another medication that does not have this side effect potentially, but it doesn't mean that they're going to experience it. Some people are perfectly fine again, but they cannot just stop their medication because they're likely to now have a seizure again. Looking at your hirsutism, your hyperplasia, your gingival hyperplasia. So when you're looking at this, very, very, very common with this hyperplasia. And so what happens is their gums, like you see in this bottom picture, they get enlarged, they'll start to cover their teeth. We can fix it with surgery. You can do a gingivectomy, and then you need to switch them off of this medication if you start to see that this is happening. Don't let it get horrible. Some of these cases that we see, like their tooth is like little chiclets, like little small little tic tac. Like, how long were you on this medication? Like, you didn't see when it initially started to happen. And when they come back and they're talking to you, if you see somebody that's on this medication and they're talking to you and you kind of see their gums looking kind of funny, you should look and be like, they're on this medication, right? Or have they taken this medication? There is a fix for it. They just have to have surgery. And then if they're a woman, they might not want to see their coarsening facial features, right? I don't want to be like chiseled, and I don't want to have to start growing hair. So like it kind of hardens you. So when you think about this, just think about like the bigger things are going to be your hirsutism, your gingival hyperplasia, and then that coarsening of the facial features. So you see her, she has her beard going on, and she's just not looking great. Her chin is getting chiseled, okay? So instead of me being round out, right, I can start to have this occur. So just pay attention to that. Your dose related. You can see the rash. Remember we talked about SJS and TENS already. Very serious. Some patients, if it gets really, really bad, they end up in the burn unit. We end up treating them. And then sometimes this one you'll see also where they have nystagmus, right? And their eyes are going back and forth. That's when you know like your dose is probably too high for that patient, okay? If that is what the only thing is that is managing their seizure, then you're going to need to switch them to a different medication, right? Ataxia, confusion. So when you see this dose-related slurred speech, this is us thinking toxicity, essentially, right? My dose is too high for that patient. Blurred vision, dizziness, a thick tongue, like them feeling like they can't talk, which is why you start to kind of see and hear that slurred speech that they're having. And then less common, the only one that I really want you to worry about there is that hyperglycemia because of your arrhythmias, because of your patients having any type of underlying cardiac or diabetes issues would be a thing where now we're having to adjust some of those other medications. Contraindications in my patient who has an arrhythmia, right? Because I can kill them. I don't want their heart to not beat properly because of another medication. I would just switch them to something else. But with my hyperglycemic patient, like with hyperglycemia occurring, I can tailor their insulin or their metformin, whatever I'm giving them for their diabetes a lot easier than their heart meds. Pregnancy, don't do it. So that's why you see her with the baby in her belly telling us that it is not safe in pregnancy, teratogenic, okay? It can be very harmful. Our interactions, a lot of them, okay? That's what I want you to remember is that there are a lot of interactions. You have it as a substrate, you have it as an inducer, so it will have levels decreased when it's in the presence of some drugs, and then it could decrease the levels of some drugs when it is in the presence of those. So our big drugs that I want you to pay attention to is that you have anticoagulants and contraceptives that can be effective. This is a big deal because you have several women who could be in childbearing age who do have seizures who are on contraceptives because they do not want to become pregnant. And if you put them on one of these medications, you can then decrease the effectiveness of their contraceptive that they're on. What does that mean? I got pregnant and I didn't want a baby. Now I'm coming for you, okay? So just make sure that you understand the effectiveness of your contraceptive will be decreased. When we're talking about our anticoagulants, this is what I was telling you with your anticoagulants. Just understand that they interact with each other. Because as you see here, I can increase my phenytoin levels, but I can also see where I can decrease or increase my anticoagulant effects. So just understand that they're acting on each other, okay? But with your contraceptives, not a good idea. A lot of interactions with our SIDS, okay? And once we get through this phenytoin, we'll take our break. Narrow therapeutic index drug, okay? So you see that it is also one of those things where you have 10 to 20 micrograms per ml. Still need you to remember the level. But this is a drug that if you see a person on it, they're going to be going in to get their levels drawn for us to monitor to make sure they're within that range. Because if not, those dose-related adverse effects that we talked about, they're going to start experiencing those, okay? That's also a hint that your person is outside of their therapeutic window, okay? Zero order kinetics, meaning that the levels of that drug is gonna change as you continue to give them their medication. Intoxication occurring if you increase that dose, right? So if I increase the dose, I'm expecting to see that dose level increase as well. So just make sure that you understand that we are very, very worried about somebody who also loves to drink while they're taking this medication. So just, again, protein binding, another big deal, right? If I have that protein binding occur and now I have to compete, now I'm going to see those levels. I can give them that same dose, right? But now I can see if I have to compete with somebody that now with that same dose, the level of unbound drug that I have can now increase because I have to compete with this other drug who wants my same receptor. They want my same partner. Okay, now we gotta fight it out, all right? So that's all that this is saying. So a decrease in protein, the availability of it, or if there's some type of reason as to why you have hypoalbuminemia, can result in an increase in the amount of drug that I have free. So my phenytoin is not bound anymore because the protein isn't there. And then you see that you have the same total drug concentration. So that same drug that I was giving them now has an increased effect because more of it is free just from the fact that it's not bound, okay? So remember that principle that we talked about. This is just looking at, again, a picture of what we were just talking about. So making sure that other drugs that you give that have protein bounding, that you're thinking about the effects that it would have if somebody is on phenytoin. So even if you are not the one who is managing that patient's phenytoin, if you're considering putting them on another drug, you need to reach out to that provider, that other PA, that other doc, and say, hey, I'm considering this, and I know that it interacts with phenytoin. How do we want to approach this? Or you can just look for another drug that is not going to have that competition and that protein binding to mess with their phenytoin level. Because if they're controlled with those seizures, you don't want to mess with that, right? And we see it's a narrow therapeutic index drug, okay? So with that one shift, right, you gave them that one drug. Now I have more unbound drug. Now I can see those toxic dose-related effects that we talked about. Because now phenytoin is out there living it up. It's free. It's not bound. All right, 10 minutes. So 11:55, come back and we'll keep going.
Last night. Oh. I went out because I had at noon. I had to go see my academic counselor to sign my welcome back counselor. and then I came back in because I was eating. I'm like, I'm not gonna go early. I'm gonna go early. It's never available. And then my team's like, oh, easier now. So I stopped eating, went over, came back, finished eating here, and I went out like around like 12:20ish. I was on the right side one. Like, yeah, like if the bathrooms are behind you, like I was on the one. Yeah, that's why. So like you, PFAS sends the money out like 5 days before the day you get paid. The banks have to process it. So the banks have the money for that paycheck. That's why you will only get paid on the first. The money doesn't like get paid on the first. But it will affect the 15%. You know, that doesn't get released until that December. So by that time, you don't get much of anything. That's all because of the so the bank still has to process it. That's not anything to do with you guys. The bank will have access to it.
It's because she went to the board. It's because she went to the board. But like,
That's the whole reason why they have like they all have very similar I thought like $100. But I still thought on like that when he was all I assume that's not
Hey, don't worry. He's taking care of us.
nice.
With our rent. They made sure to send a newsletter out. Make sure that we knew that they were still gonna fix our AC.
We don't have to-
out in the freezer house.
We don't have to move out.
Yeah, yeah. Actually, the email was like, "We need to find a new place."
Yeah.
My neighbor is a retired guy who lives on post or whatever. His kid is like considered active duty as like EMT. So in order to use
I guess like rifle program to get funded, put it in oil, that was like what's actually
so that's why they had retirement house.
but like
Back everything up, they triplets, like kind of late or licenses, they all kind of came out. Like handicap rallies. So he's an instructor, like I'm curious if he's furloughed. I was not actually
I got one of those that lives close to me. Old man. Yeah. He's like, yeah, I live right here. I was like, he's like, get his drink, get off the bus. So I was curious, like, because I've had soldiers before that put their parents or grandparents like as dependents.
Yeah, it's definitely weird having retirees, or maybe not even like 20 years or so, just like veterans go up like parents' houses on the
For Polk is like that bad. Like so many retirees live on post, but nobody wants to live on post. So they have a lot of people move on to installation.
That's kind of weird that they allow that because it's so hard to get a house on post.
I don't know about your neighborhood, but since like the PCS season quit kind of died down, there's a lot of vacant houses in our neighborhood that are like been empty for 2.5 months now.
There's somebody that was just moved in beside us, and I've seen them outside once. Like, there's no activity. I never see lights on.
Wow.
Just yesterday, I saw them walk in the house. I'm like, oh, shit, there they are.
They live there. Yeah, maybe that's happening, but like we saw somebody move into a house last week, but there's There's like 3 of them that we can see from our back door. I know don't have anybody in it.
Our street, we had like 5 or 6 that were empty for a while, and now they're all full.
Yeah.
My wife said somebody's decorating like big time for Halloween, like down the road. So there's like pig heads and stuff hanging from the tree. She drove by, said our 3-year-old was like, he's like scared we dropped that.
You know, if you've ever been over to that side or left out like the new Brunswick Gate, they have like all those major houses that kind of sit in a ring across from those quadrangle. They're huge houses, like double wraparound balconies, you know. And there's one major house up the street from us that like glows orange and purple every night. It's all decorated, decked out for Halloween. You go walk by it, they got all the inflatables out. Yeah, it's like we don't. I can't remember the last time we did anything for Halloween. They don't really celebrate it in Germany. But like,
I go trick or treating, but I don't like putting anything up.
yeah.
All right, I had a couple questions, so I want to go back real quick. Sorry, because there's too many people asking me to say it again. So when we look at this zero-order kinetics, when you're talking about your zero-order kinetics, I guess trying to liken it to something that's more relatable is like alcohol, right? What this means is I can increase my concentration, and if I continue to increase that concentration, I'm likely to see more side effects. My body isn't going to metabolize it. It's satchable. So think about I went to the bar and I had a drink, right? I had my one alcoholic beverage and I was like, ooh, and I started to feel great. It's starting to get metabolized, right? And then I'm going to start to eliminate it. I broke the seal. I went to the bathroom. And that's whenever I can be like, oh, maybe I can have another drink now, right? Because I have started to excrete my alcohol, right? It got metabolized. Let's say I just sat at the bar and I had 4 or 5 drinks, okay? That would be interesting. I had 4 or 5 drinks. And I sit there and I'm like, okay, I am feeling this, right? Now I feel like I'm gonna throw up. I have saturated my body's ability, right, to process and break down the alcohol. So now I'm intoxicated. I am feeling toxic effects, right? I want to throw up. I might have diarrhea. All the good things that come with us drinking too much alcohol, okay? So when we're talking about phenytoin, same thing. What this is saying is if I had a person on 300 milligrams and I wasn't getting the response that I wanted to see, and then I just increased them to that 400 milligrams, it's still saturated. Like if my ability to metabolize that phenytoin is already at capacity and you increase my dose, now all you've done is increase my toxicity, the chances of me having those dose-related adverse effects that we talked about, okay? So that's why these were broken down to say non-dose related, meaning if I were taking this at a regular dose versus my dose-related, okay? So once I increased that dose and I started to see my patient experience this, they're likely in that toxic range because they were already saturated, okay? So when I see that, I know I need to back down on my dose. I can then choose to slowly titrate that person and decrease their dose and see how they're dealing with the medication, or I can say, all right, they're not responding to phenytoin and I would switch them to something else. When you're looking at the protein binding, different concept, but it's talking about protein. How much protein is available in my body? So if I have a lot of protein available to bind, I'm going to probably require more phenytoin because it likes to bind to protein. If I have less protein around, and I gave phenytoin, that means that like now there's more of it free floating around because it's not bound to anything, okay? So more protein, you're gonna see your levels get affected. Less protein, you're going to see your levels get affected because phenytoin is highly protein bound, all right? So what that means for you clinically is if you are doing levels or drawing levels for your patient, or if you prescribe a drug to somebody who you have on phenytoin, and it's also a highly bound drug, like our anticoagulants. That's why you see these interactions with some of these anticoagulants, because now they're competing for that protein binding. Okay, so that's why you can see the effects of either of them get altered. Because now what they typically rely on is messed up. Now I have more free drugs, so I'm gonna get some more anticoagulant effects, or I could get less anticoagulant effects because I'm competing with phenytoin, who also likes my protein. Okay? So that's what these two concepts are. They're two separate things fit onto this one side. So maybe next year I'll flip it and do it the other way, because I think everybody's thinking that this all goes under like your zero order. Same type of idea though, right? So how much protein do I have for binding to occur? The more protein, the more bound, the less effect that I'm going to see from my phenytoin. The less protein, the less bound, my phenytoin is likely to be toxic to me. Okay? More protein, maybe I'll have a therapeutic failure, right? Because it's bound so much that I may not have my drug active. So I can have a therapeutic failure. Okay. Phosphenytoin sounds like, what did we just talk about? Phenytoin. But phosphenytoin is just the prodrug of the phenytoin, right? Same mechanism, just remember, oh, it sounds like phenytoin and so it's a prodrug. All right, clinical uses, status epilepticus, you'll also hear this as SE. So status epilepticus, you have what we have as our IV formulation to help load some of our patients if we're trying to, or maintenance dosing in place of phenytoin. If we're trying to get them on phenytoin, we can also bridge with this. So good medication for us to use, just that you see that it's IV. Looking at this, I don't need you to remember what you're going to mix it with. Just understand that we're not giving it like straight out of the vial and injecting it into our patient. We're going to run it in a bag. Don't remember your administration, your PK. Remember that it's an inducer, okay? So it can increase the effects of some of our other medications that we have. You can see the therapeutic failure occur depending on if it's a prodrug or if it's a regular drug that was acting on that CYP. So remember CYP inducer, okay? Don't worry about your administration. Just know that these aren't equivalent. So if you had a patient who came in, or if I asked you, hey, if I gave 1 milligram of phenytoin, is that equal to 1 milligram of phosphenytoin? No, they're two separate drugs, so they're not bioequivalent, okay? So that means that you're going to have to do a dose adjustment. I don't need you to remember what it is. Just know that you're going to have to, you can't just, it's not a 1-for-1, okay? Carbamazepine or your Tegretol, very, very common medication to use. We only have this available as an oral medication. You see that it can cover some of those focal seizures that people are experiencing, some of our generalized as well. So very diverse medication. We also sometimes will see this used in our patients who are experiencing bipolar symptoms. We use this medication there also. Looking at your pharmacokinetics, big thing that I want you to remember here is that it is an auto-inducer of itself. This is the first time where we have seen a drug that does this. They also love to test on this on every exam possible. They want you to know that carbamazepine is an auto-inducer. So essentially what you'll see is that what that means essentially is that it can metabolize itself. So it doesn't really need, we talk about CYPs and how we need CYPs for metabolism. Well, this drug can metabolize itself. So what you'll see in the initial, usually like the first 1 to 2 weeks of us using this medication, what you'll see is that the concentration or the dose of it will be less. The levels will be less. So when you're trying to get your level for this, wait at least a month for you to get an accurate reading on what your levels would look like in that patient. Because it's going to auto-induce itself. It's going to auto-metabolize itself, right? So you're going to see that drop. But after that month, it should level out, and you'll see kind of what your dosing and what your response is in that patient. Looking at our adverse effects, several different ones. You see that just like we had with our phenytoin and several of our other drugs that we're going to look at, that you have that sexual dysfunction that can occur. Diplopia, or like having blurred vision and seeing two of things whenever they're looking. Usually is going to happen with their first dose, and after that first dose we see this subside, and it's not something that's going to be like a permanent thing, so it's like a quick thing. So remember, your first dose within that first hour is typically when they'll see this happen, and they do regain their vision. Then, as they continue to use the medication, typically within 2 to 4 weeks, but up to 8 weeks, you can see where they start to develop a rash, okay? These timelines are important, and I want you to remember them because these are some of the symptoms that you can see your patients come in with, and you knowing kind of where they are in that timeline does matter. So your rash in that first 2 to 8 weeks of treatment can sometimes pop up. If you see that rash happen, then you should discontinue the medication, put them on something else to help control their seizures, but know that they can't tolerate your carbamazepine. Your syndrome of inappropriate antidiuretic hormone, or SIADH, this is something that is very hard for us to kind of treat. So when we're looking at this, this is essentially our ability for us to retain water. You have to look and rule out several other things. So when we all talk about SIADH, you'll know a little bit about that. And then weight gain, okay? If you have somebody who is an active duty service member, depending on why they're on this medication, understanding that weight gain could be a big deal for them, especially if it's somebody that's, like worried already about height and weight. So just keep that in mind as you continue to practice with some of our meds when you see that weight gain. Adverse effects. So our more serious adverse effects that we have, the ones that can be more deadly to our patients, is bone marrow suppression, hypersensitivity that could essentially be fatal to a person due to just their organs kind of shutting down, essentially. So when you look at this, they can have lots of different coagulopathies that could occur and essentially be detrimental to them. Hepatotoxicity, osteomalacia, and then that black box warning for your SJS or your TIN. So that's why if you're seeing within that first 2 to 8 weeks that rash occurred, that's why you're going to stop it, because it's indicative that that is what is going on, that they're responding to the medication and they're going to get that SJS and the TIN. Yes.
So, ma'am, is that the same case for the phenytoin? Is it genetic thing or just intentional?
So it could have a genetic component to it, but it could also just be some people are responding to it. We don't know that we should test for a genetic marker prior to putting them on it. It's something that we find out after we have put them on it. And we're like, oh, and it's not a fun situation. So if you pull them off of it, you should be able to see that they're gonna be okay. With our carbamazepine, this one we do know that we do test. I have not seen them test for fosphenytoin for our HLA-B, but I will check and I will answer you, but I haven't seen them for that. For this, I have definitely seen them. We do test. But for our phenytoin, most of the time we're like, oh, there's that rash. Shouldn't do it. But you can also test and somebody can still respond this way. Okay, so this is a marker that says that they are likely to have this happen, but it doesn't mean that it will always happen because they have this marker. But I wouldn't start them on it if they do have it. If that makes sense. So you're looking at your HLA-B and your HLA-A. We'll talk about both of them because they are unique to certain populations. So we'll see Asians and African Americans who will display these alleles more, which means that they're more likely to have your SJS or your TINs. And then looking at your aplastic anemia or your agranulocytosis, again, all these things are super serious things that we're worried about our patients getting that could be deadly to them if they get them. So we'll go down into the breakdown of what these kind of look like when we're talking about our SJS and our TINs. So again, delayed for that 2 to 8 weeks. So if you start to see this, we're going to discontinue our medication. You see that more of your people are going to have your TINs than your SJS. Okay, so that's giving you just that breakdown. And then we're titrating this medication when we put them on it slowly because if we see that rash starting to appear, we are hoping that by us being on a lower dose at that point and it happening within that first 2 to 8 weeks, that it won't be as drastic and all over their body. Not to say that for some people it still is not all over their body. Okay, so just understand that it is something that is rare, but it is serious when it does happen. And then these are some of the other drugs that we talked about with our SJS and our TINs that could happen. NSAIDs is probably like our lowest threat that we have, but our anticonvulsants and those antibiotics, we do see our SJS and our TINs. Looking at our monitoring that we have. So LFT, CBCs, because remember when we were just talking about that black box warning and all of the different things that could occur, we had all of the hypersensitivities that could happen. So when we were looking at our agranulocytosis and our anemia, this is why we're monitoring. So we get our baseline, always remember to get your baseline, and then you're gonna check again within that first 2 to 3 months. Some people will push to the 3 months just because they can remember to do it easier. And then once you see that your patient is stable, then you're just checking once a year. Most people do once a year. They cannot go to that 2 years thereafter, like they'll do every year where they'll check. And if your patient is coming in for regular checkups, we're gonna get a CBC anyway. And your LFTs, you typically are pulling them. So you'll know every year how they're doing with the medication. Looking at our interactions, lots of interactions. So most of these meds that we talk about for anticonvulsants, just make sure that you're running that interaction checker, okay? There is a gazillion interactions with these medications. Again, whenever I go into this, I will definitely let you know how in-depth this is gonna be with, like, if you need to know that it's gonna increase a level or decrease a level. So I'll get back to you guys on the depth of that whenever I'm looking at the questions. Because yes, it was great to break it up, but now the questions get a little bit more, I'm shooting fish now in a bucket instead of in the ocean, right, with your 50 questions. So I'll let you know how this will shake out. Looking at the contraindications, several different contraindications, meaning I'm going to try to avoid it, or that means that my monitoring is going to be even more strict than what it was before. So bone marrow suppression, MAOIs, we'll talk about them. We don't use them very much anymore, but you'll see that they do come up, and we already talked about MAOIs. And then our antiretrovirals. So if they're using these medications, they interact with each other. So if you are going to have a patient who is on an MAOI, typically we will say that washout period is still 2 weeks before we would start them on the carbamazepine. So they need to stop whatever that MAOI is that they're taking before they start the carbamazepine. Okay. Not recommended in pregnancy. Most of these meds are going to be that way where we're not recommending. This was that genetic testing that we were talking about. So when you see your HLA-B or your HLA-A, these are the ones that were more likely to have that rash occur. So whenever we see this rash starting to happen, we stop our medication. We can recommend that they have the HLA-B 1502 if they're of Asian descent, and if they are of African American, Asian, European, Indian, all of these Latin American, so almost everybody, your HLA-A, okay? So just remembering the two that you have, HLA-B, 1502, HLA-A, 3101, okay? So this is what we're gonna do, we're gonna test them. So it is not a requirement that you do it, but in practice, most people will do this because you don't want to deal with the SJS or the TINs. It is very harmful to your patient, like it is not comfortable. Oxcarbazepine or triliptal, again, still dealing with our fast sodium channel blockers. PK parameters that we have, you see that it has carbamazepine kind of in it, right? Your carbazepine. So structurally similar to our carbamazepine, not as potent as it is. We do see that we have that inducer effect, but we don't have the auto-induction that we saw with our carbamazepine. So remember, that is unique to your carbamazepine. Are my doses or are my levels of my carbamazepine in that first couple of weeks going to be reflective of what I'm typically going to see in my patient? No, because I auto-induce, okay? On top of the body metabolizing it, the drug is metabolizing itself. So you wait a month to see at least what that is going to have, like what it's going to level out to for our patient. In our oxcarbazepine, we're not worried about that. There is no auto-induction, okay? And then when you see this epoxide intermediate, this is a part of the carbamazepine metabolism that we see that auto-induction. It also helps with that auto-induction. So this is just telling you that it doesn't have that. All you need to know, no auto-induction with your oxcarbazepine, but with your carbamazepine, you have your auto-induction. Your general uses listed there. Again, you see that we're using this not only as an anticonvulsant, but I'm also using this for my patients who have bipolar disorder, or if they have any type of neuralgias, we can sometimes get a benefit for them. But again, not something that we typically go to. I do see this used, but it's typically because they can't tolerate that carbamazepine because it interacts with so many different things. So the decreased potency that you see with your oxcarbazepine is sometimes why we use it because it's not interacting as much with some of those other drugs. But if a person isn't on a lot of medication, we're typically okay. Adverse effects. Again, less potent, not as many adverse effects that we saw with our carbamazepine. What we're worried about here, though, is going to be looking at our hyponatremia. And then you see the vision, that's still coming up again because we were talking about diplopias and all that with our with these meds so far. So that's coming up again. Just when you're thinking about this, think of this as your baby carbamazepine. Okay, so less potent, so less effects. I'm not worried as much about the hematological issues, but it does not mean that they don't happen. It's just less common, okay, because it's less potent. Interactions, again, we have our oral contraceptives that are affected here, and then looking at your calcium channel blockers, that's kind of a minimal thing, but just make sure you're looking at that. When you see that these decrease or reduce the effectiveness of your oral contraceptives, does that mean that you don't give them this medication? No, you can still give them this medication. What that means for your patient is that they need to have a backup method, okay? They need to use a condom. They need to practice abstinence, whatever it is, to make sure that they're not getting pregnant. If they're going to tell you that they're refusing to do that, then you need to make sure that they're educated and understand that they can become pregnant, okay? So they need a backup method because it's not saying that it's going to completely make the contraceptive not work. It's saying that it's going to decrease the effectiveness, right? So I may not be 100% covered. Sometimes what we'll do to combat this is we'll give them a higher estrogen component in their contraceptive so that that decreased effectiveness will still kind of be in the range that we would want to see. But when we increase levels of estrogen, we increase several other side effects that we're going to talk about next semester. So it's kind of like you're trying to find the balance in between the two, okay? All right. Looking at our primidone and our phenobarb, or phenobarbital, mechanism of action here is that we're saying that we're increasing our GABA chloride influx. Remember we said GABA was what? Inhibitory. So in this patient, I do want to see the increase in that GABA function, okay, to stop the firing. Looking at my phenobarbital, a big thing for you to note is right at the top, this is a controlled medication, okay? We see that we can use it for several different types of seizures or for my patients who have refractory status epilepticus. Typically, when we're saying refractory, they've been in that seizure for more than 5 minutes and we cannot get out of it with any of our other anticonvulsants. That's whenever you'll see us sometimes pull our phenobarb and we'll use this. Inducer, look at that. We're seeing that it is another inducer. And then our monitoring, just make sure that you're looking at like your levels. If somebody was on this for a long period of time, if they were taking this like as their maintenance drug. For the most part, it's a good medication. Helps with anxiety, the higher the dose. If you give them a high enough dose, you'll put them to sleep. Okay, it's a good drug. So just make sure that you're understanding that we can get good effects, but this is one of those ones that because it is a control, it has a high abuse potential that we're like using it as a last line kind of thing. Okay, we don't want to initially start with this for the most part. We have several other options. Looking at your adverse effects, we have hypotension. We didn't see this in a lot of our drugs so far, so that's something that is going to be significant because depending on the hemodynamic stability of your patient at that time, this could tank somebody. Bradycardia, same thing. That is a big deal when we're looking at this. Your sexual dysfunction, we've been seeing that hyperactivity can be another thing that you can see with some of your patients. And then when I think about this drug, I think about it's slow outside of the hyperactivity. It's kind of slowing everything down, right? Cognitive impairment, my brain isn't working well. I can't have sex. My blood pressure is dropping. My heart rate is dropping. So the only thing that was kind of excitatory here was the hyperactivity that could potentially happen. That's how I think about my phenobarb, is just kind of like snowing me. Contraindicated in pregnancy, which was what we were talking about with most of our drugs. And then if there's any type of airway obstruction, because you see I'm already slowing everything down. So if I have any type of airway obstruction, this is not a medication that I want to give, because if I do need to intubate somebody, if I do need to try to save them, then I'm going to have more issues, and they're likely going to die. So we try to look at these contraindications and link them to those adverse effects. Your interactions, several CYP interactions, if they're on any other medication that can cause CNS depression, slow anything down. So think about like a beta blocker, a calcium channel blocker. If I'm an alcoholic, all of that is like slowing stuff down, okay? So you'll see that those have now additive effects. And then again, our contraceptives, right? Decreased effectiveness. Primidone. So we're looking at our primidone, same type of mechanism that we talked about before. You see though that this can be metabolized to two active metabolites, one of which was the phenobarb that we have talked about. Okay? So when you see this, just think about the fact that like, oh, I'm getting this drug, and then it's being broken down to these two other things that still have action. So therefore, when I think of this, I can think about the fact that I have a longer duration of action. This is one of the meds that we kind of use last line. We don't use it as often as we used to anymore. So you see your grand mal seizure, your psychomotor or focal seizures. These are really big seizures that some of your patients can have. They're very your patients are convulsing very, very badly. That's when you'll see us using these. Your off-label use of that trimmer, you will see different conditions that can cause a tremor while we can use the primidone, but some people we don't love it, we kind of stay away from it. Adverse effects aren't horrible, but you still have a lot of, it's just the older drug. Maybe used with my carbamazepine or my phenytoin if I am not achieving the levels that I want and I want to do like a poly, right? I want to add on another drug. This is one of those ones that we'll see typically used in conjunction with, but again, it's kind of further down the line. Like you tried, you got them to the max tolerable dose of that other drug, and we still weren't getting a response, then you can add that on. Adverse effect, make sure that you are titrating this slowly because again, we have that nystagmus that can occur, some ataxia. It's a pretty well tolerated medication, it's just the older one that we don't use often. Again, our contraceptives, and then we have the fact that it's a CYP substrate so that its medication, its levels can be affected by some of our other drugs. Also, when we see this with our contraceptives, another thing that I wanted to say is that we do have different options like IUDs or a copper IUD that we can use in a patient. We don't love copper IUDs, but if you have somebody who needs anticonvulsant therapy and we can have a decrease in the effectiveness and they don't want to become pregnant, it looks a lot shinier, okay, that copper IUD. Benzos. We hear about benzos a lot. We'll talk about them in more depth, but these are going to also be control medications. So our second control class that we've seen, you see it down here with what we're acting on. So it is helping increase that GABA-mediated influx that we'll have. So again, acting and binding, helping that GABA receptor get bound to, essentially. When we're looking at our use of benzos, people used to use benzos a lot, now people abuse benzos a lot. And so we try not to prescribe them often, and if we do, we're trying to give them for a very short term. So it's not something that we typically love to leave our patients on. You see that we have diazepam, lorazepam, clonazepam, and clobazam. Several different formulations of these, depending on how your patient presents with what type of seizure that they have. We have several different formulations that we can give. So for instance, is diazepam. Orally, the brand name is Valium, but we have one that you can also use rectally that's called Diastat. And so if somebody is seizing, right, I can't give them a medication by mouth. I can do the rectal. I can also try to give it to them IO, or if I have a line, I can do it that way as well. So just understanding that having different formulations with our benzos is very beneficial for us and our patients who have seizures. Our adverse effects, because I can use these for anxiety, just think about you kind of like mellowing somebody out, right? Like drowsiness, they're just kind of calm, they're kind of off a little bit, like they're in the clouds, okay? So those behavior changes, the ataxia, all of that, just think of it as kind of like mellowing somebody out. I told you that you have that, it's a control. So when you see this, if you leave somebody on it for a very long period of time, you can see them go through withdrawals from this medication when you try to take them off of it. So that's why we don't want them to get used to it, and that's why we typically only leave it on for a short period of time. We will also try to use the lowest dose that we possibly can. If they're actively having a seizure, you give them this medication one time, they're not likely to go through withdrawal symptoms unless you gave them like a huge dose. They're not likely to go through any type of withdrawal symptoms. They're just gonna be like completely sedated and out of it. Gabapentin, pregabalin, and your ethosuximide. Our mechanisms of these are going to vary, so they're working in different sites. So you'll see that you have the alpha subunit calcium channel, so it's not really on that GABA receptor, and then you have the T-type calcium channel when you're looking at your ethosuximide. So again, your GABA is over here, and then your ethosuximide isn't even pictured on here, but those are looking at your T channels. So if you see varies on here, that means that I'm not probably going to ask you about their mechanism of action. So just look at them here, same things that I was telling you about already, but your clinical use down here, you see several different types of seizures. Also with your gabapentin, this is that drug that I was telling you about that is used off-label for so many different things and like commonly. So when we talk about this, yes, we use it for seizures, but it's typically added to some other anti-seizure medication. But when we are talking about that post-herpetic neuralgia, that is a lot of the times where we will see our patients using this for any type of neuropathic type pains. It's typically where you're going to see gabapentin used, whether it's associated with their diabetes, whether it's associated with some type of viral infection. So sometimes people get shingles, and then afterwards they'll still have like that nerve pain from their shingles outbreak that they had. So we can sometimes also give these doses of gabapentin to help them. We can also help our patients who are addicted to alcohol, sometimes kind of taper them with these medications to help them with that dependence as well. So gabapentin is like a very old medication where you can see super low doses, or you can see humongous doses where like they're on grams sometimes of this medication. All right, so it's not uncommon because some people will say like, oh, it's not working anymore. So when I look at this one, because of how much you're going to use it, just make sure that, how would I ask you this? Look at these two things, because these could be two ways for me to ask this. Look at these two things and know your clinical use for this one, because I will probably ask you about this, because you're going to use this, okay? The real ones and your off-label uses, because most of the time when you're prescribing this, you're going to prescribe it in your off-label capacity. So I do want you to know that. Okay, PK parameters is dosed very, very frequently. Make sure that you're going to you're renally adjusting this medication. Okay, so make sure you're paying attention to that. So big thing here, dose frequently, renal adjustment. Adverse effects that most of your people are going to say as to why they don't like it is because of the drowsiness. That is the biggest thing. When you see this tremor, it is initially when you're first starting the medication or when you have increased their medication to a very high dose. That does go away in your patient. So your big thing is with the tolerability for your gabapentin is people are going to say, oh, it just made me feel like so bad, like I felt horrible and I couldn't take it. And a lot of people will want to stop the gabapentin, even though it may have. They don't even get to the part where they get the benefit of the medication because they don't like how drowsy they are. Okay. So drowsiness is a big one for this one that I want you to realize. And then that initial tremor, that does go away over time. Pregabalin, another control medication, Lyrica. We prescribe this, we dispense this all the time. So again, very similar mechanism that you see. The clinical uses also very similar. So just make sure that you're looking at the similarities. What you see here though is that we do have more like off-label uses when we're talking about our pregabalin. So like our generalized anxiety or GAD disorder, you'll see that we're using it for that. Restless leg syndrome is added on here. So there are slight and subtle differences, but again, another very, very popular medication that you will prescribe. Unlike the gabapentin, this one is a control medication. They are talking about if they want to make gabapentin a control medication, but just for class, it is currently in this setting, it is not a control medication. Looking at our PK parameters looks very similar to what we already saw. A big thing that you want to make sure that you let patients know of, again, is that sexual dysfunction, you can also see those CK elevations happen in our patients. So just monitor them. If somebody is very sensitive to this medication, and it could be deadly, you can see where they do have some angioedema. So just be mindful of that. You may also have patients come in and complaining of swelling in their lower extremities. That's usually where we will see that edema happen in our patients who are taking Lyrica. So just some of those very subtle things that people will complain to you about could be because you started one of these medications that's super common that we prescribe all the time. With your Lyrica and your gabapentin, you will see that weight gain is also another concern. So just great drugs, but again, the side effects that we have sometimes when we're looking at these can be not fantastic. If they don't taper off and they've been on them for a very long period of time, we do see some people complaining about discomfort with the diarrhea, but it does go away. They'll just be uncomfortable for a couple of days. Ethosuximide. So when we're talking about this medication, this was the one that I told you has the T-channel calcium current. So the way that I remember that is that it has the etho with the T. So I remember like the blocking the T-channel, the T calcium channel. So when you're looking at this one, the clinical use is very simple for us to remember. It is an important one for us to remember because this is our drug of choice that we use in our patients who have absence seizures. Okay, and this is like one of the two maybe drugs that we have to use. So it's important for you to remember this. Your adverse effects, not horrible, right? So very small, minor things. Looking at this, your hematological changes that you can see occur in the neutropenias, those are your more serious, of course, things that we would be monitoring. So that's just us looking at our CBC, making sure that our patient is okay, especially when we're initiating it. And then if you start to hear your patient complaining about any of these things, then of course we can monitor more frequently for that. BPA, valproic acid, and all of the derivatives that you see. So several different channels that it is blocking, and then they're also acting on that GABA production and trying to prevent it from being degraded. So it's kind of like indirectly acting on your GABA, and then you see some of that T-type calcium channel current that's being affected. What else did we just talk about that had the T-type calcium current? Ethosuximide, right? And what was ethosuximide used for? Okay. All right. So when you're looking at this, your valproic acid and your derivatives, you see that they all have like valproic or valproate in it, right? Valproic acid, valproate, and your divalproate. These are very common drugs also that are used when we're talking about our seizures. You'll also see us using it in our patients who have epilepsy and different types of, several different types of other seizures. So the way that I want you to kind of remember this is using it for your seizures, second line for your absence, because remember, if we can remember that both of these have that T, right, our T calcium current, then we can remember that we can use those both for our absence. And then you see that I can also use this in my patients who have migraines. We don't typically get here, but if you do, it is an option for your prophylaxis. So if I was telling you that I was having so many migraines a year or a month, you would be like, oh, well, you qualify for some prophylactic treatment. And then I would take valproic acid every single day so that I could prevent myself from having a migraine. And then looking down here, you see that when we talk about using this in a IV formulation, so that's what we're saying when we say parenteral use, they're saying that you're only doing this if there's a reason why your person is NPO, where they can't take anything by mouth. That's the only time where we should be using this. You will see that there are very few situations where we will use it not according to the FDA label, but that's on an inpatient side. We would deal with that person if you were there. So I won't ask you about the parental use. Like what I need you to know about parental use is that we're only using it if they're NPO. If they can't take anything by mouth, that's the only time. That's the only thing I need you to know here. All these other reasons as to why we sometimes use it, don't worry about that. Interactions, understand there's lots of interactions. When we look at this, if I were to be having a patient who is on more than one medication, which is likely, right, when we're talking about these meds, you can see here that I'm saying that I can increase my levels if I had them also taking Lamictal or lamotrigine. I can also now see that I can increase my levels of that epoxide accumulation that I had with my carbamazepine. What was unique about my carbamazepine? What does it do to itself? Auto-induction, right? So this accumulation could then cause me to experience, bless you, more side effects when I'm talking about my carbamazepine. And then inhibiting my metabolism of my ethosuximide, well, that sucks because now it's not going to work, right? So trying to put these two medications together is not going to be beneficial for me, all right? I can increase me having the side effects now from either of these medications when I'm using it. Adverse effects. What's kind of weird here? Alopecia, we haven't seen that yet. Nausea and vomiting, and with this platelet aggregation, I could have a comorbidity where I have something wrong where now you're telling me that I can't, I may not be able to form clots. So if I had cut myself, I might be bleeding more now. So interferes with platelet aggregation is a big thing. More weight gain, you see that happening. Looking at your more serious thing, your PCOS or your polycystic ovarian syndrome is something that can happen. And then again, that hypersensitivity that we talked about with the organs and then that thrombocytopenia. We've been seeing this kind of happening with a lot of these meds, okay? So when you're studying, start to make your list of this abnormal bleeding, your alopecia, and the aggregation, your platelet aggregation are all things that happen with your BPA. Alopecia is an A, aggregation is an A, and then my weight gain, adding on weight is an A with your BPAs, okay? BPA for your valproic acids. Your box warning that you have, we don't see these happen very, very often, but making sure that you're not giving it to your pregnant women because it can be teratogenic is very important. But you also see the hepatotoxicity, the pancreatitis that can occur. So LFTs are going to be monitored. Also making sure that, again, you are, if you see a pregnant woman, because you're likely the ones who are going to see those pregnant women first, if they are on a BPA, like it, or any one of those derivatives, you pull them off of it, okay? Lamotrigine or your Lamictal. Mechanism of action here, you see that you have your glutamate and aspartate. So when we talk about glutamate, unlike our GABA, glutamate is something that excites. So I'm trying to decrease that firing, right? So I don't want anything that's going to excite in these patients. And then it's going to delay that firing that's happening, which is good. And then we also see where we're right back into this box, I'm acting on those sodium channels. Several different seizures that you have, our LGS is a different type of it's like a childhood epilepsy that your patients could have. So we do see these a lot. These also come in chewable formulation for those kids who do have LGS who take this medication. So just make sure that you're aware that, again, great med, not affected by food. So that's why you're going to deal with this medication very easily. Our interactions decreases the effectiveness of our contraceptives. You see that contraceptives, and then looking at this, your BPA can deal with or decrease your lamotrigine or your Lamictal metabolism. Okay. So what that means is I can have increased side effects. So looking at my black box warning, I'm going to make sure that I'm doing a slow titration because I don't want, again, to see this SJS happen. You see that this is, again, more likely to occur in our PEDS population, and we do use this medication often in our PEDS population. Making sure that you are looking at your adverse effects, again, not very abnormal ones except for this aseptic meningitis that you see there, so that serious inflammation of the lining in the brain that patients could have. And then on this one, I do want you to look at these interactions and see if you have decreased lamotrigine levels, these are the drugs that are going to decrease your drug levels, and then you'll see your increase in your lamotrigine levels happening because you have it with this other drug. So if I have it with valproic acid, so just like we talked about our BPA, we said that it interferes with our lamotrigine. You see that it's going to increase my levels. I don't need you to know what happens. I just need you to know what, if I'm telling you that the levels of lamotrigine increase, I'm likely talking about valproic acid. If I told you that the levels were decreased, oh, what am I talking about? Carbamazepine, phenytoin, my contraceptives, rifampin. We are seeing something that is unique here. What's different?
Pregnancy.
I can use this if I'm pregnant, which kind of makes sense and should help you remember I'm using this in my kids who had the LGS, right? I can use this in those children as well. So I can use this now for my pregnant ladies. We will start here. I will have more answers for you tomorrow. We'll finish this lecture and then we will finish our Parkinson's, and then I will let you know if I'm going to do an in-person review or if I'm just going to post questions for you guys to work through and just be available. So I'll let you know.